Good morning. My name is Brandon Nurn, and I'm a registered nurse in the emergency department, and I have been with our hospital for the last 2 years. Today, I want to take this opportunity to discuss a potential quality improvement initiative regarding our current sepsis policies and procedures. We have all heard that sepsis is fatal. We have heard about sepsis care plans and to always get your blood cultures prior to antibiotic administration. But do we fully understand the detrimental effects that sepsis is creating? And do we appreciate the severity of the situation to the extent that our clinical practice reflects that? Unfortunately, research has proven we are not. In the first 6 months of 2023, we were below the national benchmark compliance rating of 81% in 4 of those 6 months. Each year in the U.S., over 1.5 million people are diagnosed with sepsis, and around 250,000 die as a result. Sepsis can begin as a simple infection that then manifests into a multi-organ dysfunction and lead to death without early recognition or treatment. Not only is this a problem for patients, but it also affects hospitals' revenue. Without the appropriate procedures in place, financial loss can occur in the form of reduced reimbursement. Research has proven that specific interventions, including sepsis screening, better understanding of the diagnosis, and care bundles lead to better outcomes. After conversing with coworkers and leadership in the emergency department, it was clear that sepsis identification, treatment methods, and documentation were an issue that needed to be addressed. The Centers for Medicare and Medicaid Services, or CMS, have established goals to improve the medical community's approach to managing septic patients and decreasing mortality. By adhering to those guidelines, we can decrease the number of sepsis fallouts, increase our reimbursement from CMS, and most importantly, improve our patient outcomes. Currently, our process isn't working. Recently, there's been high staff turnover, and this has impacted not only nurses, but physicians as well. Due to new doctors and new nurses working together, the ability to recognize criteria for sepsis and initiate early treatment has continually been an issue. Our process requires nurses to initiate the sepsis protocol or refer to the physician's documentation and order sets. Unfortunately, young nurses with minimal experience are missing key indicators and failing to document appropriately. While efforts have been made to try and reduce the number of fallouts, they are still constantly occurring. A code sepsis sheet was created with the criteria and specific steps to follow. However, the location of these sheets varies throughout our unit, and staff does not always comply because the sheets are not an official part of the medical record. Within the electronic charting system, there is a sepsis questionnaire that's supposed to be filled out for every patient. But again, this is overlooked or misunderstood by staff. And finally, the largest stride that Glenwood has taken to reduce the number of fallouts is re-education. But again, unfortunately, this training is only done annually, leading to a large lapse in time where information tends to be forgotten. Since recognizing that meeting or exceeding the national benchmark of 81% compliance has been an ongoing issue as determined by staff and recent data, I recommend we initiate a sepsis care bundle, reevaluate our triage process, and begin re-education monthly until meeting our goal of 81% compliance or better for 3 consecutive months. After attaining our goal for 3 consecutive months, certain strategies can be adjusted, such as monthly staff meetings or interviews. By reducing the number of fallouts, we're improving our patient outcomes, decreasing their length of stay, and increasing our reimbursement from CMS. Specific recommendations. The changes I suggest for triage minimize the risk of error due to inexperience or lackadaisical tendencies. Multiple studies have shown significant improvement in compliance when utilizing an automated triage system. By revising our questionnaire to be specific to sepsis and using this to triage every patient, the signs and symptoms can be flagged by the EHR instead of the nurse conducting triage. Then, the electronic health record, or EHR, will require that nurse to contact a provider prior to completing the triage so that the appropriate order sets can begin immediately. Once a patient is recognized to be septic, a specific care care bundle should be initiated by the provider. This care plan should include an initial lactic draw, blood cultures, fluid resuscitation at 30 mL per kg, and a broad spectrum antibiotic. If any part of this bundle is contraindicated due to another condition that the patient has, the provider must document a reason to avoid a fallout. It is also crucial that the patient's vital signs be monitored and recorded at a minimum of every 15 minutes. Research has proven a decrease in mortality when abiding by these guidelines. And finally, re-education must be done more frequently. This will instill urgency around sepsis. Monthly staff meetings and individual interviews with nurses and providers should occur to see if the changes are working or need to be modified in some way. In order to evaluate if these interventions are effective, data should be recorded monthly and compared to the 6 months prior. This should include quantitative and qualitative data. Quantitative data will be represented by the number of fallouts, the length of stay, and if reimbursement was given by CMS. This will be collected by our sepsis quality coordinator as well as our clinical coordinator through chart audits. The qualitative data will be gathered through interviews conducted by our clinical coordinators in each unit. This will include nurses and providers that are most affected by the initiative. With the support of leadership and this committee, I believe initiating these changes can make a substantial impact. This will increase our return from CMS and allow more available beds so we can provide better services for others in our community. Providing efficient and patient-centered care should always be our priority, and by actively striving to improve processes such as this, we can achieve our goals. Thank you.